So, the next part, well, good morning everyone. I was a bit late because I thought it was in another place. So I think you also did.
Yes, I did the same.
Because we discussed last night, it's there. Anyway, we are here, fortunately.
Yes, we both got.
And I'm very much looking forward to the next session, which will be a debate between John Hyatt from Australia. Well, John, in actual fact, started in England. He's very well known for all the work that he did in first trimester scan, and especially on the correlation between nuchal and heart anomalies. And he will be in favor of screening in the first trimester, at least I hope. Let's say that's what we thought.
Yeah.
And then there will be another speaker, which will be Gustavo, and he will let's say, defend the cause of the scan a little bit later, not at 11 to 14 weeks, but let's say at about 16 weeks, the Israeli way. Anyway, looking forward to it.
Good morning, everybody, and thank you for inviting me to talk about the potential advantage of doing a scan at 12 weeks compared to that late start at 14 to 16 weeks of gestation. I believe in population-based screening, I guess a bit like some of the statements Anne made at the end. And I think that the important aspects of population-based screening is that everybody has access to a robust test, and that the test is done to a high standard, that there's good quality assurance. And I think that there's bags of data out there about doing a scan at 12 weeks, which really supports our ability to use this on a routine basis in clinical practice. So what are the issues? Well, if we just cut to the chase and look at rates of perinatal death, this is Australian data, and if you sort of tidy all causes of perinatal death up into some subgroups, there's really probably four major pillars. Some are related to congenital abnormality, others related to preterm labour, others to placental insufficiency. The one on the left, congenital abnormality, you can subdivide into two groups: chromosomal anomalies and structural anomalies. We have a whole host of unexplained deaths as well on the right-hand side, and when we look at the relevance or the potential relevance of a 36-week scan or screening test, it really comes back to this cohort. So I'm not going to concentrate on that today, but I think the potential relevance of doing a population-based scan at 36 weeks is about trying to reduce late stillbirth. So we've all come to know this concept of a 12-week assessment process as the pyramid, and I guess that we should really call it the Nicolaides pyramid. Fundamentally, what it's doing is flipping standard antenatal care and practice on its head. So what normally happens in antenatal care is that we gradually see women more and more frequently through pregnancy. And the reason is that that's a reactive process to the risk of hypertensive disease in pregnancy, because for many years we've recognised that hypertensive disease in pregnancy is a problem, and we've also recognised that it is more prevalent at late gestations. And we know that it's very difficult to predict, and we know that typically hypertension occurs before a bad outcome. So typically we've screened women more and more frequently at the end of pregnancy to be able to react to their rise in blood pressure. And fundamentally, what we should do is flip the resource around so that we spend much more resource at the front end of pregnancy, defining levels of risk, and then hopefully having some interventions to prevent some of these bad outcomes, rather than just reacting and delivering babies prematurely and putting them in neonatal units. So with the Kipros process, you can see there's a 12-week scan, and there's a 20-week scan, and then potentially a 36-week scan. So the real question is, can you afford in this process to put in that 16-week scan as well? Or what are you going to do as an alternative model? Are you going to remove the 12-week visit and remove the 20-week visit and just consolidate with one 16-week test? From my perspective, I think we will be missing a trick with many things that we can do at 12 weeks that we aren't able to do either by 16 or 20 weeks of gestation. So I'm going to start by just looking at the 12-week scan and its relevance to screening for chromosomal abnormality. I don't really just want to talk about the data in terms of the sensitivity and specificity of a nuchal translucency scan, but what I want to do is talk about it from a structural perspective, a philosophical perspective. So the image on the left is a fetus that has Down syndrome. It has an increased nuchal translucency, it has an absent nasal bone. The real question is, how do we describe that level of risk? Now, some of my American colleagues are now describing themselves as personalized fetal physicians, which I assume means you can earn more money. But the reality is that we've been doing this for the last 15 years. We've been describing individualized level of risk to fetuses on the basis of what we can see. And the reason is the graph on the right-hand side. It's the recognition of the fact that the bigger your nuchal translucency is, the higher your level of risk of a chromosomal abnormality is. And then taking that a step further and developing statistical models to look at the likelihood of you being in a normal population or an abnormal population. So we end up with a philosophical approach to screening that looks like this. Whenever we see someone at 12 weeks, we should start by defining their background level of risk. We can then measure things, and you can measure biophysical things, let's say with ultrasound, and you can measure biochemical things. And provided those things don't interact too much, you can actually use them all as different markers in the same equation, and then take your a priori risk based on your history and manipulate that to give you a final adjusted risk after you've looked at your markers. This process is important, not really now for Down syndrome screening, but for screening for all potential anomalies in the first trimester. So in the context of first trimester screening, what it means is you can take your nuchal translucency, you can take your biochemistry, and you're producing a test that has a defined false positive rate and a defined detection rate. Now, how could you take that forwards? If we want to do NIPT in a contingent model in Australia, somehow I have to knock some money off the budget of what I'm doing already. Interestingly, the easiest way I could do that is to stop doing the biochemistry. If I stop doing the biochemistry, then the efficacy of my first trimester screening test actually goes down a little bit. So actually, to get best performance within my contingent model, what I should do is drop the biochemistry and save the money from that, and then I can add other ultrasound markers to my first trimester algorithm. And the one that I would pick would be looking at the ductus, and you can see here that when you get an absent A wave, a reversed A wave up at the top of the picture, that's associated with aneuploidy. It's actually also associated with cardiac defects, and we've known that for a long time. This is data from Alexandra Matthias back in 1998. More recently, that's been modelled in a different way, so instead of just looking at absence or reversal of the A wave, you can actually look at the pulsatility index of the ductus venosus, and here you can see that you can then compare the PI for different groups. You can see that the trisomic groups all have a biphasic distribution. And so, again, like nuchal translucency, you use a very complex method of modelling called a mixed model. It's a non-parametric model to allow you to develop likelihood ratios that give you risks. And from an aneuploidy perspective, I think we will be using contingent screening, potentially just with ultrasound markers, so that we've got money in the bank to spend on NIPT, and probably the ductus venosus is the most useful marker. But the reason it's the most useful marker is because of its contribution to other areas of screening. So I'm going to just move towards structural anomalies now, having set that baseline. There's actually very, very few studies that have looked at large populations and looked at the impact of a first trimester screening test on looking for structural abnormalities. These are the early data sets, published up to about 2002. And you can see that at that point, there was about 1/3 of structural abnormalities that were detected within the first trimester. The data is superseded by a publication in 2011 from Kypros's group on nearly 50,000 women. Singalaki is the first author, and basically they defined anomalies that you almost certainly should be able to define at 12 weeks. Anomalies that you could define in roughly 50% of cases, and anomalies that were rarely defined. And the interesting thing, I think, during this program is that Rabi will take things from that bottom group and either put them in the middle group or the top group. So the situation continues to change. You know, this was data that reported a cohort from 2006 to 2009. So that's nearly 10 years ago now, and the situation has moved forwards.
Next will not be kidneys.
Yes, and guess who got the kidney talk? So, this was the Singalaki distribution of anomalies that they saw at 12 weeks of gestation. It's quite interesting because you can see that cardiac defects makes up about 25%, CNS defects very significant, as are skeletal and renal and abdominal anomalies. Let's just compare that actually to the perinatal death rates related with those various abnormalities. So you can see that cardiac made up about 25% of the anomalies. It's also by far the most significant defect in terms of perinatal death and deaths in infancy. And then you can see that CNS defects are also important from that perspective. So in the context of this debate and just wanting to choose a couple of examples, I'm going to stick to cardiac and CNS. So what are the implications of increased nuchal translucency? Well, we know that that's associated with an abnormal karyotype, but we also know it's associated with major fetal abnormalities and actually with death shortly after that scan. So we can use nuchal to start to stream our patients in terms of looking for structural abnormalities. And in fact, for cardiac abnormalities, we know that the bigger your nuchal translucency is, then the more likely it is that you have an underlying cardiac problem. Now, Rabi will tell you that you should not bother looking at the fetus's neck if you want to define a cardiac abnormality. He will tell you that you should just look at the heart properly. And I fundamentally agree with him entirely. But for mere mortals, I think actually recognizing whether the nuchal translucency is large or small is at least helpful in that process. And if you look at current indications for fetal echocardiography, this was a paper that was published a few years ago, which included the relative yield by indication, and you can see that nuchal translucency is in fact the most significant factor in that process. The reason I wanted to do a ductus in the first trimester, to add that to my screening protocol in my contingent model, is that I know that if I take a nuchal translucency along the x-axis here and then add the finding of an abnormal ductus, that they're synergistic in screening for cardiac disease. And they help improve the detection rate, you can see in the middle of this chart over here, rather than using nuchal translucency alone. And everything in life has a mathematical equation, I'm sure you knew that. So this is the equation that describes the risk of structural cardiac defect on the basis of nuchal translucency, ductus venosus, and tricuspid regurgitation at 12 weeks. And the reality is that we should be applying this in every 12-week scan we do, and at the bottom it should say the risk of Down syndrome is 1 in X, and the risk of a cardiac anomaly is 1 in Y. And then you look at the heart as well. In our own practice now, for our early echo clinic, the big nuchal makes up about 80% of referrals. This is a meta-analysis of studies that have reported sensitivity and specificity of doing a first trimester echo, and certainly this is a useful tool at 12 weeks. The heart is small at 12 weeks. It's easier to examine the heart potentially at 16 weeks if you can get the fetus in a decent lie in the first place. But recognize the high sensitivity in association with nuchal translucency. That's a useful way forwards. So let's change direction. So this is more work of Rabi, who's, I think, probably the seminal player in structural anomalies in the first trimester. This is a picture that shows a normal posterior fossa in a mid-sagittal section. So it's the view we use for nuchal translucency. So it takes you 20 seconds extra time to include screening for spina bifida in your first trimester scan. And the fetus that has an abnormal spina bifida, for example, you'll see a change in the shape of the posterior fossa. And again, this is the subject of another lecture. But fundamentally, you can look at ratios of measurements, or you can eyeball it directly, and this has a very high sensitivity to screen for CNS anomalies. We seem to have a slide out of place. So when we want to screen for CNS anomalies, again, we need to put things in perspective. So I suspect that Gustavo will show you an anecdotal case or two of absence of the cerebellar vermis or agenesis of the corpus callosum at 16 weeks gestation. Are you really going to be brave enough to call them in clinical practice when you know that the corpus callosum doesn't complete its development till 18 to 20 weeks? Is it significant at all? You can see that in the context of all anomalies that we see for the CNS, 40% of them are anencephaly over in the red, 23% of them are holoprosencephaly, and 16% of them are spina bifida. Now, I will tell you that 100% of anencephaly and holoprosencephaly should be detected at 12 weeks. A-lobar holoprosencephaly should be detected at 12 weeks. I think tomorrow, Rabi will tell you that 90% of spina bifida should be detected at 12 weeks. So fundamentally, we've already got 75% of CNS anomalies defined at 12 weeks gestation. It's important just to recognize the changing epidemiology of conditions. Spina bifida is getting less important from a live birth perspective for two reasons. One is our ability to make that diagnosis in prenatal life, but the other is changes in public health practice, fortification of things like flour with folic acid. When we screen for anencephaly, it's perhaps important just to recognize that the features are different in the first trimester to the second trimester. So you can see essentially acrania here. That's perhaps the more traditional view that you might see later in pregnancy. But the other view that you can use for screening is to look at the biparietal diameter, and you'll see absence of calcification of the calvaria at that gestation. In terms of the newer method of screening, there's two ways of doing this. One is to use the mid-sagittal section that I suggested before, and that shows you changes in the position of various structures in the posterior fossa, and you can see those as well in this video clip.
Very nice.
So, and Rabi will show you that later. There's another way of doing this. You could just measure the BPD. So this is French data. They've actually now published, I think, 3 or 4 papers on this, which use a combination of screening tools. You can either use BPD alone, or you can use BPD in ratio to the abdomen, usually the AP diameter of the abdomen, or you can use BPD in conjunction with AFP. And they're picking up again with these techniques about 65 to 70% of spina bifidas at 12 weeks. Holoprosencephaly is often obvious at 12 weeks of gestation. I think it's also just important to think about the underlying cause of these anomalies and the prevalence of lethal chromosomal abnormality, for example, with holoprosencephaly is going to be much higher at 12 weeks than it is at 16 or 20 or 40 weeks gestation, and that will also potentially impact on other testing that you might do. If you were to choose to go down the road of termination of pregnancy, I think it's still important to karyotype the pregnancy because that will impact on advice for future pregnancies. So you can do all of those screens for structural abnormality at 16 weeks. And indeed, there are structures in the fetus that will grow and therefore will be easier to see at 16 weeks than they are at 12 weeks. But I think that within a typical public health budget, you have to make decisions about the best way to spend your money. And I would suggest that actually it's the screening for preeclampsia and IUGR and the screening for preterm delivery that are going to be most significant for us. Most children in our society that have problems during infancy are actually born preterm. And they're either born preterm because of spontaneous preterm delivery or because of preeclampsia and IUGR. And I think that we already can make significant inroads into that. So this was Leona Poon's data that was spoken about earlier. This is the first study where she used a risk model at 12 weeks in the same fashion as we have for chromosomal abnormality, using uterine artery Doppler, mean arterial pressure, and biochemical markers to define risks of early preeclampsia. The good thing about the model is it's robust. So we have taken that model to Sydney with a completely different population, and we use the same model and we get exactly the same answer, a 90% sensitivity. It's certainly true that we seem to be better for screening for early preeclampsia than late preeclampsia. But from my perspective, the women who get early, severe onset disease requiring delivery before 34 weeks are more likely to have health problems themselves, and for sure their infants are going to be in a nursery. And actually, if you're looking at finding economic evaluation that demonstrates the value of screening for preeclampsia, this is it. It's because of the reduction in neonatal admissions. So we now give women who have a high risk for preeclampsia aspirin. On the right-hand side, you can see our data from a recently published cohort study. We have a 90% reduction in early onset preeclampsia. The midwives in my hypertensive disease clinic complain that they don't see preeclampsia anymore. The junior doctors jump up and down in joy when we get a transfer in of someone who has preeclampsia. And we have a 90% reduction in local admissions to our nursery for delivery because a woman had preeclampsia. It saves us $700,000 a year. Should we do this for IUGR as well? This is Kipros's data. We're in the process of evaluating whether his IUGR model works in a Sydney-based population. Our biggest problem is actually our babies are all bigger than UK babies. So the first problem we have is actually defining what IUGR is in our population in 2015. Should we be screening for preterm labour at 12 weeks? Well, I think that this is realistically a research process at this point in time. I've just put this image here because I want you to recognise that measuring the cervix at 12 weeks is different to measuring the cervix at 20 weeks. You have to look at the echolucent area of the endocervical canal, because often you'll have contraction of the lower segment that makes it harder to define the endpoint of the internal cervical os. And because you're using a different technique, you need to have a different normal range. And you should recognize that the median cervical length at 12 weeks is less than the median cervical length described at 20 weeks. So that means you have to retrain your mind about what you're going to define as a cutoff for a high-risk cohort. There are defined likelihood ratios on the right-hand side, comparing populations of normal and preterm deliveries. And so you can see that as the cervix gets shorter, your risk does go up. As with most of the FMF models, this is now customized for each individual patient, and that's done on the left-hand side, so you take account of the gestation, the maternal age, a woman's height, ethnicity, and her parity. And if you put all of that information together and perhaps drop in some biochemistry, AFP again, which we mentioned when we talked about spina bifida, you can see this model has a 60% prediction of women who will deliver preterm before 34 weeks gestation. Now, what's the treatment for that? I don't know at this point in time whether giving someone progesterone from 12 weeks rather than 20 weeks is going to be better in terms of producing a better long-term outcome. So that's one of the reasons why I think that this is an R&D process. But if we give the 12-week scan up and just do NIPT and then do an anomaly scan at 14 to 16 weeks, we lose the opportunity to do this. And from an aspirin perspective, the data I showed you, if you start aspirin before 16 weeks, a 90% reduction in early onset preeclampsia. If you look at the meta-analyses that are published, if you give aspirin after 16 weeks, it's a 10% reduction. Finally, twins are really important. Twins make up 1.67% of the deliveries in our country. They make up 20 to 25% of admissions to most nurseries. We've been a bit slack, I think, at recognising the morbidity associated with twin pregnancies and making sure that we have very high standard screening processes in place for them. The first thing you need to know about a twin pregnancy is the chorionicity. This is best defined at 8 weeks. It's reasonably defined at 12 weeks. It's potentially impossible to define at 16 weeks. So again, from my perspective, if we're going to screen properly for chorionicity, we need to do it at 12 weeks gestation. And that's important because we need to recognise the significant increase of risk with early fetal death, preterm delivery, complications like twin-twin transfusion, if you're monochorionic. So we looked at our twin data, which is the bottom line here before the total. So we've looked at about 300 twin pregnancies. Interestingly, if you look normal at 12 weeks in a monochorionic twin pregnancy, 1 in 10 of those women will not take home a live baby. And the reason is twin-twin transfusion, IUGR, and spontaneous loss before 24 weeks gestation. It's really important that we recognise this risk at 12 weeks so that we can put mechanisms in place to look for anomalous development of the pregnancy, and then we can offer some of the interventions that we potentially have for things like twin-twin transfusion syndrome. Okay, so I think I've given you lots of reasons why a 12-week scanning is a good idea. I really can't think of many cons at all. I think I've highlighted some of the potential pitfalls of doing a scan at 16 weeks gestation, but I'm sure that Gustavo has other ideas for you. Thank you.
Yes. Thank you very much, John, for your very inspiring lecture. Are there questions from the audience?
In the meantime, there is a question from the web. What is the role of NIPT in twins?
So the question is, what's the role of NIPT in twins? I think first, there's not much published data for NIPT in twins, so I think you have to remind your patients that if they're going to have this test. Personally, I think that NIPT is valuable for the monochorionic cohort because it is likely that the placenta is the same, and that's the source of the trophoblast for the cell-free DNA test. So it's likely that both have the same chromosomal structure, and it's likely, therefore, in a monochorionic twin pregnancy that you get a very reliable result. In comparison, some of the markers that we use with first trimester screening work less well in monochorionic twins. So, for example, nuchal translucency can be increased because of twin-twin transfusion, the ductus can be abnormal because of twin-twin transfusion, and the biochemical markers can actually be impacted by twin-twin transfusion. So I think for monochorionic twins, NIPT is quite reasonable. I think personally it would be good to have larger data sets in dichorionic twins demonstrating its efficacy.
And there is another question. Ductus venosus reverse A wave at 11, 12, and 13 weeks have the same predicting value?
So not exactly, but again, in the models that we use, that gets built into the model. So when you're constructing the likelihood ratios, the first thing you do is account for the differences in gestational age. So I guess my answer is that with any of these measures, we should actually be using computer-based algorithms to calculate risk rather than just using flat cutoffs, because generally the computer algorithms perform better in terms of sensitivity and specificity.
Thank you.
I have another question for you, John. I think you pointed out something which is extremely important, that maybe the most important aspect of the first trimester screening is to identify patients who are likely to develop preeclampsia and maybe also growth retardation, because it provides a window of opportunity that we wouldn't have if we would screen at a later stage. The downside of this is that the implementation of the first trimester screening for preeclampsia may be quite difficult, especially measurement of the uterine artery. So my question is, what is your experience? What was your reproducibility in terms of measurement of the uterine artery? And the second question is, why to bother and screen everyone and not just give aspirin? I mean, this is an argument which has been put forward in the literature. So what is your answer to that?
Yeah. So my answer to the first part is that we find uterine artery Doppler robust. You have to recognize that there's a training process for it. You're using likelihood ratio calculated using a standardized technique, and therefore it's important you reproduce the standardized technique to use that same risk algorithm. We actually use a audit tool from the Chinese University of Hong Kong, from Daljit Sahota, which runs a custom plot of our uterine artery Doppler. So for any individual operator, you can plot all of their uterine artery measurements serially, and if they consistently either under or over measurement, then you come away from the sort of x-axis on that chart, and you can make adjustments to your method of scanning and analysis. And we find that very effective. So we run those roughly every 3 months for our operators. We've actually published a normal range for Australian uterine artery Dopplers because our sonographers like to know what roughly normal values are. And the problem with the Kipros algorithm is it's so customized that when someone asks me what's a normal uterine artery Doppler, the answer is, well, can you tell me the ethnicity, the maternal age, the parity, whether they smoke or not, and things like that. So we've published a more generic normal range for Australian population, and we've actually published a paper about quality assurance methods for uterine artery Doppler. Should you give aspirin to everybody? So I guess the problem with that is that if you look at the positive predictive value of that process, you'd be giving aspirin to, let's say, 250 women to prevent one early onset preeclamptic outcome. The screening process, we've demonstrated that we're giving 28 women aspirin to prevent one bad outcome. My personal belief is that most women don't like taking medicines in pregnancy, and I think that there are very good examples of poor compliance in programs where you just give a medicine routinely to your whole population. So my main issue is actually compliance and the number needed to treat.
Still another question, the last one. Would you screen only women at their first pregnancy, or would you rather screen everyone?
So in our observational data set, a third of the women that had preeclampsia in a second pregnancy were multips, and half of them had no previous history of preeclampsia. So, yes, the prevalence of disease is lower in the multiparous group, but I think that they are still a significant cohort. We find that it's a useful tool in multips who have, let's say, late preeclampsia before. Often are women with early preeclampsia on aspirin already, but certainly we're finding that for some women that had previously late onset preeclampsia, that we're redefining them as being at high risk for early onset preeclampsia and adding them to a cohort who should have aspirin.
Thank you very much. Do we have any new question from the...
No. Yes. There's another one. Is there any population randomized study in first trimester screening?
So, I mean, the answer is that there are some population studies for chromosomal abnormality, but none have really focused on screening for structural abnormalities. And one of the problems with that is about the construction of the trial and what you don't do for various cohorts and whether it's ethical to do that. So people who've actually tried to set that up have often had problems with a debate about the ethics of process.
Thank you very much. And now we move to the next speaker, which is my co-chair, Gustavo Malinger, and he would talk to us about the first trimester ultrasound scan moved 2 weeks later to 14 to 16 weeks. Thank you, Gustavo.
Good morning again. I think that my opinion is that if we are driving in the wrong side and our car are constructed in the wrong side, let's do that because it's good, because we are doing that. There are some problems, in my opinion, with John lecture. First of all, and probably most of us do the same. Okay, we try to polarize, to put things when performing an examination at 12 weeks, and you perform this at 16 weeks. I can tell you that we are very close. No, we are not so far today, because most of the images that are shown are most of the examinations that are shown regarding fetal malformations are fetuses that are 13 and 3, 4, 5, 6 days, or it will be exactly the same when we are doing the examination at 14 weeks and 1 day, 2 days and 3 days. So if you are comfortable doing an anomaly scan at 13 weeks and 6 days, it's okay. In your machine, you have a very good machine, and you can do that at 13 weeks and 4 days, it's fantastic. But if you are going to do this examinations at 11 weeks or 11 weeks and 1 day, the quality of the examination will be completely different. Now, I know that these works are being done from the last 15 years, and nuchal translucency is there for 15 or 20 years. But I would like to, it's a pleasure to me to present you two guys that very early, in 87, 88, Ilan Timor and Moshe Bronstein start doing fetal scanning quite early in pregnancy. And they publish a lot. And the first paper was published in the Lancet in 89. Okay, and what they show how to diagnose spina bifida. So there is nothing so new. More than 30 years ago, people started doing that, and the amount of cases they have is fantastic. The problem is that Israelis are not so organized as English or Australian people. So the acquisition of data was never our strong. And you see, again, in the 80s, 90s, they published on mid-gut herniation, caudal regression syndrome, central nervous system defects, nuchal cystic hygroma, nuchal translucency, urinary tract anomalies, heart conditions, and also ocular defects. And this is only a very, very few amount of the papers that were published long time ago. What I'm going to present you is based on the work of these people. My colleagues at the ultrasound unit at Tel Aviv Zuraski Medical Center, that actually they are doing the work for early diagnosis and doing the examinations. And particularly the images you are going to see are from Ilan and Michael. They're sitting here, and the images are most of the images are from them. Eventually, in 2-3 years, an APT will be performed to all the populations between 9 and 10 weeks. Why? Because the actual cost of an APT, not in Europe, but in India today, is 120 pounds. So the moment that the cost will go down around the world, it will go down because of competition. Every woman will have access to that, or by the national health systems, or by their own. So I think that we will not need the nuchal translucence as it is now presented, because the nuchal translucence itself will tell us nothing if we know that the fetus has not one of the trisomies that we are looking for. So there are two possibilities. We can continue doing what I call a partial examination at 11.3 to 13.6, or to adopt an extended examination at 14 to 17 weeks. If you come and say, okay, don't write 14, you can write 13.5, okay, no problem. I will not discuss you. And this adopted extended examination is the one that has been described by Ilan and Moshe Bronstein for 30 years. The first question we need to ask ourselves is, we are going to do that transabdominal? Because, for years, the standard procedure in England was to do transabdominal. Transvaginal didn't exist until the moment they realized that they need to also to measure the cervix. They realized that they need to measure the cervix. They start doing 40 years after the start of the examination transvaginal. So from the developmental point of view of the examination, the training of the physicians, it will take another 20 years until they will be able to do good transvaginals. But what to do is not simply, because initially most of us perform transvaginal, but as the machines are becoming better and better, and the transducers have higher frequencies, we start realizing that, again, you can perform, particularly in slim women, a fantastic transabdominal examination. Again, it depends on the equipment. And here I'm going to show by transabdominal examination. There are two examinations of the brain. One is performed with the Cummins regular probe, 4 to 8 megahertz. And you see very nice the anatomy of the brain. You can differentiate it, in 1 second, that this fetus has not any of the malformations that are able to be diagnosed at this time, not an encephaly, okay, no ventriculomegalia, no holoprosencephaly, no agenesis of the corpus callosum because the corpus callosum is there, the cerebellum is normal, the posterior fossa is normal, the cranium is normal. So the anomalies that you are able to diagnose at this time are excluded. But again, if you look at the using a convex linear, no, sorry, it went out. Oops. It's not this one, it's this one. If you use a linear probe, okay, transabdominal linear probe, you can see the anatomy as well. Okay, this is not available. You need to buy the probe. It costs a lot of money. But if you have the probe, you can see more or less in the same condition. Now, this is the transvaginal. Again, this is the difference. I show you, this is a 6.12. Okay, and again, you hear that it's not possible to see the corpus callosum, but yes, it's there. You need only to look for. I have the same problem that. Okay, look here, the corpus callosum will appear. We see the cranium is normal, midline is normal, the corpus callosum is here. Okay, you can say that the corpus callosum is present. You will never able to see that the corpus callosum will be eventually completely normal and have not a dysgenesis or partial agenesis. We will speak about that tomorrow. Yes, very nice. Okay, what else is important to decide which kind of examination to perform? Maternal habitus, the presence of scars in the abdomen. Women that have lost a lot of weight are very difficult to be screened transabdominally. On the other side, if the woman is after 1 or 2 cesarean sections, you should have a very long cervix plus segment, and in this case, it's maybe quite difficult to reach the fetus transvaginally. Fetal presentation is also important, and we are able to make small versions at this time of pregnancy. Again, the country idiosyncrasy. There are countries that it is quite difficult to perform a transvaginal examination, particularly if you are a male physician and you don't have a nurse, that it will be problematic. And again, it's important the time you have for the examination, because you need to ask the woman to take her clothes off, and it takes time. Now, head to leg and back in 30 seconds. Okay, this is a complete examination of the fetus, and this is exactly the time that it takes to make a record and to be able to see most of the fetal parts. I showed the lips, the stomach is there. We will see in an instant 4 chambers and the outlet. Okay, umbilical vein, bladder, legs. Okay, you can go back. It's a boy. The brain is apparently normal. Okay, and this is I took this is a boy because of the amount of fluid in the brain. I took the clip from the clips I have at home. I was willing to show you how we do that. The kidney is there. You see what is called pielectasis, absolutely normal. It's a little amount of fluid inside the pelvis of the fetus. So it's not so difficult the moment that you have it takes 2 weeks to obtain a good train. You see the eye there. Now, what else we can do, or what else we do when we perform this kind of examinations? By transabdominal, you can obtain the biometry of the brain, abdomen, all the parameters required. We used to measure the cerebellum and the cisterna magna. The moment that you see the cisterna magna is more than 2 millimeters, the chances that this fetus will have a neural tube defect are quite low. But if you want to know if someone have a neural tube defect, you can go and look at the spine for it. But by transvaginal, again, you see very nicely the cerebellum. The moment, according to an old paper by Philly, the moment that you have a normal ventricle, normal size of the ventricle, normal BPD and head circumference, and a fluid in the posterior fossa, the chances for the fetus to have a diagnosticable malformation at this time is 3 in 10,000, in 100,000. So it's 0.003% chances to miss something. But again, is what John speaks. The chart that he showed about malformations is the chart of the malformations that will be recognizable. You need to remember that around 20% of the CNS malformations, okay, are not suspected during pregnancy and are diagnostic only after that. If you perform an ultrasound examination against the corpus callosum, and you perform ultrasound MRI, and you follow the patient until delivery, 20% of the children will have associated malformations not diagnosticable by ultrasound or by MRI during pregnancy. And it is, again, when you present the number of malformations diagnosed, is of those that will be able or manageable to be diagnosed. Because if you went and do that for me, when you go back home, go to a pediatric neurological or a pediatric cardiac unit, and you will see that there are lots of children there. And there are lots of children with serious conditions that have not been diagnosed in utero. So, again, always we speak about those malformations that are manageable to diagnosis. So this is the transvaginal for the measurement. And some common conditions that are diagnosed. I suppose that you perform the examination again, this kind of cysts of this size are there. You will be also able to diagnose them at 13 weeks. It's not a discussion, but again, you saw that after what we did here. what we did here is, after seeing that something is there is looking that there is two huge groups of bilateral of choroid plexus cysts, we continue the examination, look at the cerebellum to see the cerebellum is normal, but eventually we finish by looking at the hand. Why? There is an association, clear association between presence of choroid plexus cysts and trisomy 18. So you want to know that there is not clenched hand. But remember that most of the trisomy 18 will have something else. We'll never have a case that have only choroid plexus cysts. We look at the eyes. Okay, we look at the eyes, and at 15 weeks you can see the lenses very, very nicely. You can see the lenses, but not only the lenses. You can see the here. You can see the hyaloid artery. Also here you see the hyaloid artery. But something that is important to look around is, you see here you have the optic nerve. This is quite difficult to see at 15 weeks because of a simple fact that is not well known. The fat in the fetus, wherever you have fat in the fetus, early in pregnancy is hypoechogenic. Late in pregnancy, it will be very echogenic. And this is the cause that we do not diagnose early in pregnancy lipomas in the brain, because they are hypoechogenic. We are not able to see the optic nerve because it's the more or less of the same echogenicity of the retroorbital fat. And also you can have a quite big lipoma in the spine that will go unrecognized because of the fact, again, that the fat is hypoechogenic. Okay, you need to be aware that when you start doing this kind of examination, there will be things that will be looked to you like pathological. I can come and tell you, if you are not aware of what happened, okay, look at this. This is a cataract. Okay, this is a cataract. Okay, you see it here, you see it here. Okay, but actually, when you look at the eye in the right direction, you see that there is no cataract. The lens is clear. You see also here the pupilla. Okay, and you see here the hyaloid artery that is completely normal until, let's say, 30 weeks of pregnancy. If you see an hyaloid artery later in pregnancy, it may be a pathology. Okay, look, what happened is that you go very anteriorly. Okay, when you are anterior in the lens, sometimes the lens is touching the palpebra, and you see it like an echogenic structure that is normal. This is a fetus we have at 15 weeks and 6 days, and we realize that the fetus has hypertelorism. The distance between the eye is quite big. And usually the second malformation, the third malformation are sometimes are more difficult to diagnose, but in this case it was quite clear that this fetus have a cleft lip and palate, but not only a cleft lip and palate, the brain. You see that there's a quite big amount of fluid between the frontal portion of the brain and the frontal bone. This is due to the fact that this fetus has also some kind of brain atrophy. The brain is not growing normally, so it's floating inside the skull. And if you look here, where this arrow is, you see that the walls of the lateral ventricle are not regular. Time after time, we realize that the walls of the lateral ventricle at any stage of pregnancy need to be completely regular, completely rounded. If you see that there is indentated or there are protrusion inside, it goes up and in, there is a pathology, and this is something that we have demonstrated at this time of pregnancy in quite a big number of fetus, and we'll speak about that again tomorrow. Now the palate. Also, Anna spoke about the palate and the studies. You see here a very nice palate. Okay, you see the tongue moving on and in, and we are the fetus is swallowing. So we are the tongue needs to reach the lips. Here is again from the study of Ravi showing that if the maxillar is not clearly seen, those fetuses usually will have a cleft palate that until now it was very difficult to diagnose. Most of the cases of cleft palate that are isolated are not being diagnosed. And this is a fetus with multiple malformations, but what is interesting, look at the movement. Okay, this fetus is abnormal from the beginning, not because of the structure, but because of the movement. It's very, very rare. It can take a whole life of ultrasonographists to see patients that have abnormal fetal movements, but from the beginning it's clear that something is wrong here because of the movement. The movements are absolutely abnormal, and if we continue, you will see they have a very, very severe retrognathia, almost absence of the mandible. And again, you should look. One of our problems is that when you find a malformation, you remain stuck there, and you don't go and look for the fetus. And this fetus has also a diaphragmatic hernia. 16 weeks and 3 days. Okay, it's quite clear that there is a problem. You see that there is a cleft, but the cleft is characterized by the fact that the anterior portion of the palate is normal, and the cleft is only posterior. So the diagnosis is going to be some help. Okay, you see the cleft, the anterior portion of the lip is normal, the alveolar process is normal, but the cleft is posterior. Okay, this turned out to be a case of sorry. I choose the wrong one. He was there. Here we are. Same case. Okay, you see the retromicrognathia, but look there what happened with the tongue. You see, the tongue is glossoptesis, and the tongue never reaches the lips. So you have a fetus as glossoptesis, retromicrognathia, and a posterior cleft palate. Okay, so you put. This is a Pierre-Robin sequence, but the fetus had also hemivertebra. Okay, you see the hemivertebra here and here, and this is an early sign of ventriculomegaly. I put with a sign of question, but has been demonstrated again by Moshe Bronstein that at this stage of pregnancy, the choroid plexus should fill the lateral ventricle. The moment that you have fluid between the median wall of the lateral ventricle and the choroid plexus, it's highly suspected that this fetus will develop ventriculomegalia. But this is a syndrome because Pierre-Robin sequence may be isolated, has been associated with a lot of different deletions in different chromosomes. So, but in this case, since they have also a vertebral defect, it's a syndrome that is called craniofacial microsomia. And if you want to go for the weird and the strange, this is a paper we published when we were able to show the tympanic ring in the ear. It takes time, but because the structure is there, the structure is quite big. You look at them, you see something round, close to the base of the cranium, and you don't understand what this. Eventually, this has been published in the Lancet 40 years ago by Birnholz, showing the normal anatomy of the ear at 22, 23 weeks. It's much easier to see how the tympanic ring looks earlier in pregnancy. This is at 16 weeks again. And again, it's usually of not use, but if you have a patient that have microotia and you want to see if the ear, the internal ear is normal, you can look here. And we have some cases of pathology in this paper that was published in the White Journal. Now, the esophagus. The best time to look at the esophagus is at 15 weeks, 14 weeks, because it's very clear. You see the esophagus as three lines, white, black, and white. Sometimes you're lucky, you can see how the stomach opens. Okay, this is how the esophagus opens. This is the esophagus. Okay, the wall esophagus you see also here, and you know that the esophagus is normal. And here in this image you can see the esophagus in a transverse cut, but we move to the sagittal one, and it's very important to recognize that because it's important in diagnosis of double aortic arch. The esophagus is here. Okay, again, using a good transducer, you can see it very nicely also at 20, 22 weeks, but it's more difficult because of the bones that don't let to see it so nice as at 14 weeks. And we arrive to the heart, and the examinations were performed by the same person. One is performed at 11 weeks and 4 days. The other one is performed at 14 weeks. My question is quite simple. Who think that the image is best at 11 weeks, or who think that the image is best at 14 weeks and 4 days? Where is easier to recognize a malformation? At 11 weeks and 4 days, or at 14 weeks and 4 days? Now, some malformations of the heart. So why are you showing me 3D if you are going to speak about the heart? But it's something that is more than the heart. Okay, you see where is the stomach and where is the heart that are on the right. So this is a case of situs inversus. (15 weeks). Diagnosis, please. Okay, and this is a atrioventricular septal defect, and again, these fetus have also a small nasal bone and other malformations. But usually, when you see a complete AVSD canal, it's clear that you should look for down. It's a case of 15 weeks and 5 days, hypoplastic left heart. You see only Doppler, color Doppler inside the right side. The left side is underdeveloped. Double aortic arch, and you see that inside the aortic arch, what you see is the esophagus and the trachea. Now, this is two in one, and it will be impossible for this image to recognize what happened here. We have 2 in 2. Okay, and this is 2 in 2. Okay, what you can see that you don't see in 2 in 1 the inferior vena cava. Okay, you are not sure if here if this is the inferior vena cava or the aorta, because you are not sure regarding the direction of the flow. It's a little bit too red, so it most probably go up. So this is maybe the inferior vena cava, and actually it is inferior cava, sometimes called interrupted inferior vena cava with azygos continuation. Okay, and here you see also the vena cava, okay, entering through the azygos to the right portion of the heart. And this is a fetus with organ malformations, and you can see nicely using the 3D technique the presence of polydactyly. Here it's easier to see that something is wrong because you have the two vessels, one in red, one in blue, so you know that one is the aorta, the other is the vena cava, that didn't enter the heart from below but through the azygos. Okay, here you have the two vessels. Okay, sometimes it's easier to make diagnosis from the coronal plane. We are studying the heart, and you see that instead of having one vessel posterior to the heart, you have two. Think about interrupted inferior vena cava, and this is important because sometimes, or most of the time, may come with heterotaxy syndromes, asplenia, and other conditions, anomalous pulmonary vein return. But usually, if there is isolated event, this pulmonary vein return, the prognosis is not bad. Some days ago, Ilan examined a patient, and he take the anamnesis, and the patient told him that she had when she was very young, she had a thrombosis of the inferior vena cava that was actually asymptomatic. So in her country, they decide that she need to have she probably have some kind of thrombophilia. They look for a thrombophilia, but they didn't found nothing. So during pregnancy, they started giving her Clexane. She was considered a very high risk patient, but actually what she had is interrupted inferior vena cava with azygos continuation, and not a thrombosis of the. It was in Germany, by the way. No, I'm joking. And look here that in this patient, the stomach was very, very, very badly positioned, making the diagnosis of an heterotaxy syndrome. Okay, now omphalocele and gastroschisis, again, you can make the diagnosis early in pregnancy at 11 weeks, 12 weeks, no problem. But if the omphalocele is very small, most probably you are going to miss it. And the small omphalocele may be worse from the prognostic point of view than large ones. The urinary tract, okay, we can see the kidney very nicely and very easily, and recognize that what's a normal kidney to look for the adrenal and the lung. Okay, here you have in a sagittal view and how the left kidney looks, and here you have a horseshoe kidney. You have the horseshoe kidney here. I will show you it also here. This is the horseshoe kidney that eventually is a normal condition, but in this case the fetus has also holoprosencephaly. So it's not so normal. It's quite easy to differentiate between enlarged pelvises as an early sign of hydronephrosis. Should be larger than 5, 6 millimeters. 3, 2 are completely normal. Usually if you see large pelvises, you can make a very good bid that there is a boy. Okay, you look at the kidney, you see the pelvis is a boy, you don't see the pelvis as a girl. Again, the males have much water in every place, and the girls have more tissue. And this is a case of polycystic kidneys that are quite clear that the kidneys are very pericogenic with a dilated pelvises. Bladder extrophy is quite a difficult diagnosis. A lot of times you can see that there is something inside the abdomen and think that this is the bladder. What is important to recognize that in fetuses with bladder extrophy, the distance between the umbilicus and the mons pubis is small. Okay. We are able to see the spine very nicely, to see the spinal cord very nicely. Even we are able to see at the 15 weeks the neural canal, and to look for the end where the conus medullaris ends. And you should remember, this is a paper by Aaron Salel, that the early in pregnancy, the conus medullaris may be very low and may even reach the sacrum. So it's not abnormal. It's not a tethered cord. You should wait for the diagnosis of tethered cord until the second trimester. This is a patient with arthrogryposis. Arthrogryposis is clearly defined by the moment that you see that the knees, the distance between the knees is less than the distance between the acetabulum, between the femoral head, the head of the femur. You see the legs are like this in 2D, 3D. I'm going to finish. This is a case interesting one because you see that the cranium is not well developed. The metopic suture is very, very large. The moment that you see something like that, it's the case from Mikhail Brusilov, he went and looked at the clavicula, and you see that one clavicula is very small, is smaller than the other, so you put it together, okay, and you should reach the diagnosis. You see that the frontal bone is not seen. You may think here that this is an anencephalus, but the head is completely normal. What the distance between the parietal and frontal bones is very large. Okay, this is a cleidocranial dysostosis that is usually autosomal dominant, but there are usually new mutations. Sometimes you know of the diagnosis because the mother or the father have the condition. There are people that are able to put the shoulders together. And this is the child that have a small. The left side is smaller than the right side. Again, sometimes there are skeletal malformations that are very easy to diagnose because the fetus has very, very small, long bones. Okay, have abnormal vertebra, macrocephaly, protruding frontal bossing. And actually, this is a case that we saw for the first time at 15 weeks, and it turned out the patient decided to continue pregnancy. And here you see the abnormal shape of the head is a case of trisomy 18. But it will be very difficult to make the diagnosis at 11 weeks of a bifid thumb, and the presence of a bifid thumb may be a clue for the presence of other malformations or be a clue for Rubinstein syndrome that is not easy to be diagnosed during pregnancy. Again, what you should take home, it is possible to perform an anatomical survey at 12 to 13 weeks. The quality of the examination and the details observed are better if delaying the examination for 1 or 2 to 3 weeks. So if you delay the examination from 12 weeks to 14 weeks, okay, you will be able to measure the cervix in the same way. You will be able to start aspirin if you want to start aspirin in the same way. You will be able to make all the diagnoses that are made at 11 weeks and perhaps a little bit more. The problem with when you delay the examination is an anomaly. It will need more experience to perform an abortion, for example, and this is a true problem. It's better to have a good machine, and it's better to be young than to be old. This is true forever. And again, something that we learn from experience, always you should repeat the examination, but you perform the examination at 14, 15 weeks, don't do that again at 18 or 20, but delay as much as possible the examination, because if you delay the examination as much as possible, you will be able to diagnose those conditions that are usually not diagnosed during the second trimester. Again, this depends on the law of the country and the possibilities to intervene or not if there is a serious malformation. Thank you very much.
Thank you very much, Gustavo. May we find the agreement that we should scan at 13 plus, and so that we will also be able to see the nuchal before it disappears?
It don't disappear. It don't disappear. If you have a 6 millimeter nuchal translucency at 13 weeks and 6 days, I can assure, give guarantee 100% that at 14 weeks and 1 day it will be there. And if you perform the examination at 11 weeks, what you will see is the nuchal cysts. So they will be there. But we can agree that we can perform the examination at 13 weeks and 4 days. It will be fantastic.
So the paper is open for a discussion. Are there questions from the audience?
13 weeks and 20 days.
Excuse me?
For you, 13 weeks plus 20 days.
Or 360 hours, yes, something like that. Yes. No, it's quite easy. You look here.
Yes, so
You
there are no.
go down. No, go down from here. Go down. No, take this one down. Go down.
Okay.
Thank you for your question. No, go up. We answer this. We answer. No.
No.
No question. A question for the audience. Please attack me.
So hi.
Yes.
Gustavo.
Hi.
So, I mean, fantastic images of a Down's fetus with an AVSD that should have been diagnosed 4 weeks previously. I mean, I agree that the images are fantastic, but fundamentally, 2/3 of what you showed us, we could have dealt with 4 weeks earlier.
The problem, I don't know in your country, but in my country, we're a totalitarian country. And women want to know everything. And you cannot tell the woman, you are at high risk to have a malformation. Because the moment you say you are at high risk to have a malformation, she will become crazy. She will want to know, I don't want to know high risk, low risk. I want to know my risk. Okay? And I want to know for 100% that you did the maximum to detect this malformation. So if you say, okay, you have Down syndrome, well, thank you, doctor, this is not our population.
So the women that I give a diagnosis, or used to give a diagnosis after an integrated test of Downs at 16 weeks, the first thing that they would say to me is, why didn't you tell me this after the first part of the test at 12 weeks? So I think fundamentally women are obviously different in the UK and Australia to Israel,
yes,
because they would prefer to know early if their fetus has an abnormality.
Yeah, the chance to make a diagnosis of an anomaly need to be clearly low when you perform the examination early. You will diagnose some of them. I am not saying, but I am able to recognize regarding something that is very clear. Let's say speak about holoprosencephaly.
Yeah.
Okay, say we perform the examination 11 weeks and we diagnose holoprosencephaly. I can tell you that probably in this audience there is someone with holoprosencephaly that has not been recognized. So the scale or the severity of the malformation is very important. And you say by yourself, okay, I cannot recognize, or it will be very difficult to recognize a case of semilobar. We recognize a lobar, but of semilobar, are you going to be able to recognize a case of mid-interhemispheric variant? Are you being able to differentiate between agenesis septum pellucidum or not? I am not saying that this is for all the patients is the sine qua non. What I am saying is you perform the examination a little bit late, you will diagnose more than you perform the examination a little bit early. That's all. Regarding twins, I was not winning, but regarding twins, okay, I think I don't know here, but in my country. The moment that the woman is pregnant, the physician performs the examination at 7-8 weeks to know that it is not an ectopic, there are not twins. So the examination is performed at 8 weeks. And in this case, as early as you perform the examination is much better to make the diagnosis of twin and of chorionicity. So it will be extremely rare that the patient come to us for the nuclear translucent without knowing that it's twins.
Over the chorionicity. Over the chorionicity.
Or the chorionicity.
Okay, so in fact what you're advocating is an 8-week scan so that you can do a 16-week scan.
No, we do the 8-week scan because we don't want to miss the ectopic. We don't want to miss the ectopics. We want to know, is this twin? We want to know if there are twins.
So my experience of the anxiety of first trimester ultrasound, scanning people at 6 and 7 weeks gestation to see whether they have an ectopic or not, is that probably half the time we have a pregnancy of unknown location that we spend 2 weeks chasing around. And so I would have said that there's more morbidity associated with a routine screening test at 6 or 7 weeks gestation than there would be than purely doing it to find the odd ectopic.
We perform it at 7-8. Okay, and it's very rare to have a case with unknown location, because at 7-8 weeks, if it's not in, the woman has not bleeding, you look for, and my technicians come and say, okay, come, there is an ectopic, there is an ectopic, there is an ectopic. They found the ectopic. The unknown place of the ectopic depends on the quality of the examination. Okay. Because if the ectopic is there, you should see it.
Well, let's change tack a bit. Feel free to jump in. Oh, sorry.
Hi, I'm Luisa Liluzio from Italy. Okay. I didn't run a prospective study, but I have the feeling, when I perform an anatomical scan at 12 to 13 weeks, usually I choose the modality of the scan, regarding the position of the uterus, the maternal characteristic, the length of the cervix, and I'm able to perform usually very quickly an anatomical scan transabdominal or transvaginally. When I have patient coming at 16 weeks, it's much more difficult because you can't perform the whole examination by transvaginal scan because the uterus is too low, it's not close to the probe, and it's more difficult to perform either the examination by transabdominal. So you have to jump from transabdominal to transvaginal, and sometimes I'm not able to perform the whole examination also because the fetus move less than 12 to 13 weeks. So I think if you have a good probe and you can perform a good anatomical exam, the best period, if you are not in a hurry because of an AIPT test performed before or later, we can perform a very good anatomical scan between 12 to 13 weeks. And usually I'm not happy even at 13 weeks plus 5 days because it's more difficult in my opinion. I don't know if you can share your experience about that. Thank you.
I think that I suppose that the problem is that you have forgot that you have a left hand. You forgot you have another hand. And this hand is very important in ultrasound. Because, again, you use the hand to put the fetus where it is. If the woman is not 120 kilos, it will be extremely rare. Maximum you need to go to change from 6'12" to 5'9". The moment that you use 5'9", I don't realize you have a big problem at 16 and 7 weeks. And you move the fetus.
I move the fetus at 20 weeks. I think it's quite difficult to move it at 16 weeks. But I don't, this is my feeling. But
at 20 weeks?
It's easier to move the baby than at 16 weeks.
But you don't move the baby, you move the fetus.
Okay, the fetus.
But the baby, the fetus.
I speak with patients about
baby. No. You don't move the baby, you move the uterus.
But you're absolutely right, because if you think about that 13.5-week fetus, it's gradually getting more and more vertical, and it's harder and harder to get those axial sections. I mean, what depresses me most on an ultrasound list is the 15 to 16 week fetus. By far the easiest scans I do are at 12 weeks and at 20 weeks.
Okay.
There is another question from the audience.
Assuming that the gold standard is 22-week pregnancy detection of malformation, what is your feeling? How much malformation you are detecting at this time of 11, 12 weeks of pregnancy? So and I'm talking about everything, polydactyly, cleft lip.
Yeah. So I think polydactyly.
Things like this.
So polydactyly, I find relatively straightforward at 12 weeks. It's easier to see hands at 12 weeks than it is at 20 weeks. It's easier to see.
I'll make it shorter from you. What is the number?
I would say about 75 to 80%.
Would you consider our feeling of 99 to find
what at 16 weeks?
Percentage.
I'm sorry, I just don't. All I see is anecdotal pictures. I saw some beautiful cases. Show me some data. Show me some data that you can do a nuchal translucency scan at 15 weeks. You can't.
I can show you the data. Finding 90 to 95% of malformation.
Yeah.
At the 15th week of pregnancy.
Yeah.
Will it be sufficient for you to move to this time.
Well, I would want
For
to,
screening.
let me put some caveats in, okay? Is polydactyly important in all circumstances? So firstly, let's perhaps subcategorize defects into major and minor defects. And second, let's think about what the outcome is going to be when you make that diagnosis at 16 weeks. I'm sorry, but in my practice, when I read my embryology, the concept that the corpus callosum is developed at 16 weeks, it just doesn't fit with the literature. I am not going to terminate a pregnancy at 16 weeks gestation for apparent agenesis of the corpus callosum. What am I going to do? I'm going to bring them back after 20 weeks when that process is supposed to be complete. When I look at the cerebellar vermis, it's the same. I'm not saying that you can't define some process or suggestion of anomaly, but again, there's the issue of what are you going to do with that information and the anxiety that you're producing.
But you are doing the same. If you perform examination at 13 weeks and you see that the vermis is abnormal, you are not going to perform an abortion. You are going to wait.
I'm not doing the same.
We are waiting.
I'm not doing the same. I've defined in large studies a cohort of anomalies that we can really get a handle on. And others, we're quite openly saying, I can't detect that at this early gestation. And I will come back and have another look for that at 20 weeks.
But again, it's the same if you perform the examination at 13 weeks and at 20 weeks or at 15 weeks. You will wait because you know that certain conditions are not diagnosable at this time. So we are in the same position. You are not going to make a diagnosis against the corpus callosum at 13 weeks. But most probably you are not going to suspect the against the corpus callosum at 13 weeks, that I will be able to suspect that then the patient probably is a problem, come back.
And more than that, let me remind you that some of the malformations are not reasons for termination of pregnancy, like polydactyly, but having a CMA.
Mm-hmm. Yeah, absolutely, and I accept that.
Then it is very important for the genetic consultation to know about the polydactyly, not in terms of termination of pregnancy. And this is something that you miss while doing it at 12.
There's always going to be swings and roundabouts. So, okay, I might have a lower detection rate for structural anomalies at 12 weeks than I would at 16 weeks. But the reality is, in the context of everything that I'm trying to achieve in one examination, personally, I would prefer to do that at 12 weeks because I think I get a bigger bang for my buck. Now, if you ask me, would I be prepared to add a 16-week scan after a 12-week scan for the whole of my population? The answer is yes, I can see that the pictures are fantastic. But is the government going to allow me to pay for that? No. So if I have to make a choice between 12 weeks and 16 weeks, it's going to be 12.
There is another question from our friends from far away, and in actual fact we go a little bit back to your lecture, John, and they are asking, in those who are screened positive for early onset preeclampsia, would you consider anything in addition to 75 milligrams of aspirin?
Yes, another 75 milligrams. So I
Exactly.
always give
So
them 150 milligrams and give it at night. So let me say that again, 150 milligrams at night. There is a circadian effect with the aspirin, and if you give 75 milligrams, then you will find that 30% of your population will have some resistance to that dosage. So if you're going to give 75 milligrams, you need to check their platelet function, and that is quite difficult actually to do on a population basis. So you're better to give 150 milligrams, and in that circumstance, only about 5% of women would have some resistance.
You wouldn't give vitamins or other things, antioxidants?
So it's a very interesting question. There are people doing trials looking at things like clexane, low molecular weight heparins, looking at statins, looking at metformin. So there's a variety of other drugs. I think that aspirin as a first step has the advantage that it's cheap and it's safe and it has relatively few side effects. Drugs like metformin, for example, about 45% of women have some GI upset with that. So I think, again, from a compliance perspective, aspirin is your best first shot.
Regarding prospective studies, this study was published in the 90s by Yaguel and Agiron, where they showed that they were able to diagnose most of the malformations that were, they have almost no miss. But again, the problem is we perform the examination, because you perform the examination, you feel comfortable at 12 weeks. No one will say no. But the problem is how many persons in your country are able to perform the examination more or less at the same level. And this is also a problem with our paper, that most of the papers are published by people that are completely dedicated to that, and it's very difficult to speak in population. We are able to see the nuchal translucencies perform. And I don't know, perhaps in Australia everyone performed perfect, but in Israel the quality of the nuchal translucence examination is quite bad. So a lot of people come to us that ultrasound were performed by physicians, very, very well known, and we say, no, this is not possible. This is not, cannot be done. So it depends very much in the person. Okay.
Yes, well, we have to wrap up. I think we're two very interesting questions. We will probably remain with some doubts, and we could discuss a lot more about who of you is right. Anyway.